of my passions has been the evaluation and management of insomnia, which makes me different from a lot of other sleep doctors because insomnia is not easy. But, you know, if you ask, most of our patients have some difficulty with initiating and maintaining sleep, whatever the root cause of it is. So I created this talk over a period of years to try to give you an idea of how I approach insomnia, both from the evaluation and the management. So I'm going to share my screen now. Hopefully I can do this right. Screen. Okay, let me do this. All right, and go back here and swap these screens. Hold on. Give me just a second, folks. There we go.
All good.
Yeah. All right. Jody, what do we see right now?
I do not see your
Slides?
slides, no.
All right, let me do this.
Would you like me to pull them up?
No, no,
Okay.
no, I got it.
I knew that was coming.
PowerPoint slideshow.
Yeah, so hit you see the share screen.
Okay,
I see you're
how's that?
starting. There you are. Perfect.
That's it. Great. Thank you very much. And all right. So these were the course objectives that you were provided with prior to registering for the course. I'm not going to read through everything, but I do want to talk somewhat about the impact of insomnia on the society. We want to go through the definition from the ICSD-3 and talk about the different components of a chronic insomnia assessment, and then look at the components of cognitive behavioral therapy briefly. And then I want to spend a good amount of time on the actual pharmacotherapy for chronic insomnia, because that's something I'm really passionate about, something I really enjoy. So when I was creating the latest version of this talk, it was last spring, and I had to give grand rounds in May. And I was trying to figure out a way to tie everything together. And lo and behold, a couple of days before my talk, a patient who was an absolute nightmare sleep patient came into the clinic, and it seemed to tie a lot of things together. So I'm old school. I like to do presentations that you know, have cases along with them to try to illustrate stuff. So this is a patient who I saw for chronic insomnia, and she had a pretty long history, but I'm going to go through it pretty quickly. She had a sleep study that was done in 2014 as part of an assessment for bariatric surgery, and she does not recall ever having any OSA symptoms. Maybe she was snoring. She did have, at that time, some difficulty initiating and maintaining sleep all the way back to 2014. She was diagnosed with obstructive sleep apnea. She doesn't know any details about it, but she was prescribed a CPAP, which she never really used, and she returned it after about 3 months. So she had her bariatric surgery, and she went from a weight of 279 pounds to 169 pounds from October of 2014, when she had the surgery, until summer of 2015. these were exact quotes from the patient. She said when she had her weight loss, she went through a self-described wild periods when, quote, I did a lot of bad things. Basically, she started drinking alcohol daily, also binge eating, and she started to regain weight at that time. Now, by the beginning of the pandemic in early 2020, she developed anxiety because she was cooped up at home with her boyfriend and 3 school-age children. She increased her alcohol consumption even more, and then she started to use cannabis at the same time. By June of 2021, she regained most of her weight back to a weight of 239 pounds. She decided that she needed to clean up her act, and so she tried to cut down on alcohol and cannabis and food, and she started juicing. But the problem with juicing is she didn't realize the amount of calories and sugar that she was consuming with her juicing. She started to have increases in her blood glucose, which she didn't have before when she was heavier. She was determined to be pre-diabetic, and then she realized that she had alcohol dependence in order to fall asleep. So she couldn't fall asleep without drinking in the evenings. Officially, she was declared diabetic in March of 2022, which was a few months before I saw her, with a hemoglobin A1C over 12. She was started on metformin and then self-DC'd that, just said she wanted to try to lose weight again. So the current status at the time of her first visit with me was that she was not working. She was still at home with her youngest child, and her boyfriend had left her. She was abstinent from alcohol at that point, but she was using THC/CBD gummies along with a large dose of melatonin and chamomile tea in order to try to help herself to sleep. She did lose her weight back down to 183, but she still had not been able to manage her diabetes with the diet alone, and still had a high hemoglobin A1C. And she was sort of doctor shopping for management of her diabetes at that time, and she was referred to me for her sleep problem. What she told me at the first visit was that she was in bed at 9:00 p.m. Her sleep onset latency was about 4.5 hours at that time, so she wasn't falling asleep till about 1:30 a.m. Some nights she says that she wouldn't sleep at all. She would be out of bed anywhere between 7 a.m. and 9:30. She felt like she was never ever really sleeping at night because she was literally waking up every hour to urinate because of her uncontrolled blood glucose. And then she was napping throughout the day. About 4 hours every day she would nap. So she was getting about 7 hours of sleep in a 24-hour period, but most of it was napping during the day. So I'm going to cut now to sort of our diagnostic criteria from the ICSD-3. And for those of you who don't have it, please get it. Mine's sitting right next to my computer here. And when I want to make sure that I'm doing something just right on something that I don't see all the time, like circadian rhythm patients, and I want to make sure my nomenclature is perfect, because that's what we do, I always refer to the book. But so the diagnostic criteria for chronic insomnia is basically difficulty initiating or maintaining sleep, waking up earlier than desired, and for children, resistance to going to bed and difficulty sleeping without parent or caregiver intervention. In addition to that, you should have daytime symptoms such as fatigue, malaise, attention, concentration or memory impairment, or impaired social, family, occupational, or academic performance. Other features of chronic insomnia would be mood disturbance or irritability, daytime sleepiness, behavioral problems for children, reduced motivation, etc. Insomnia cannot be due to inadequate time for sleep or circumstances for sleep, and it has to occur at least 3 times per week over a period of 3 months and not disturbed by another sleep disorder. Now, by the time they make it to us, it's usually an every night thing. And in my practice in California, inevitably 90% of people are already addicted to sleeping medications. So the time factors is time spent falling asleep greater than 30 minutes, or wake after sleep onset greater than 30 minutes, sleep efficiency less than 85%, which is a pretty high bar, occurring 3 or more times per week, again, for 3 months. It's further broken down into the 3 different types. You have acute episodic insomnia, which is occurring for at least 1 month, but less than 3 months. And then the persistent or chronic insomnia, which I already mentioned. And recurrent insomnia is when somebody has either acute or chronic insomnia that occurs 2 or more times in the same calendar year. Interestingly, if you look at the difficulty initiating, maintaining sleep, non-restorative sleep, and ask patients in a general internal medicine clinic, about 30% of adults will endorse some of those symptoms. And then about 10% of people will endorse the complete definition, which includes the daytime impairment. So it's a really big problem. I've started to get more of our primary care people to, address these questions with their population. Leads to a lot more referrals, though. I've kind of already talked about this: a decreased quality of life, daytime fatigue, poor mood, and impairment in your job or your family or your social life. The important thing is that chronic insomnia can lead to other problems. So if you have daytime impairment, you can have accidents. Patients develop depression and anxiety if they go for too long without sleeping well. As in the case with my patient in clinic, they can develop substance abuse where they're using alcohol, cannabis, or pills in order to fall asleep. And there is some evidence that poor quality and quantity of sleep leads to accelerated cognitive decline and maybe a risk factor for dementia. And there's an unproven link to a shorter lifespan for patients who have inadequate sleep. Patients who have chronic insomnia have a greater number of provider visits, are more likely to be taking sleep pills, and in their workplace, they have decreased productivity, workplace accidents, increased absenteeism, and property damage. So the sleeping problems, lead to problems in patients in their jobs as well. So I learned this when I was a sleep fellow myself. You may have been exposed to this already. It's the 6 P's and an M of insomnia. And it's a systematic way of evaluating patients. If you would look at my template that I use when I'm seeing a new patient with insomnia, I actually have bullets for each one of these where I can, click on and expand and say, does this patient, fit into this criteria? So I'm going to spend a little bit of time going through this right now. Predisposing factors include genetics. So many people who have chronic insomnia describe having a parent who also had difficulty sleeping throughout their life. Things like parents who have difficulty with limit setting and have, when children have difficulty self-soothing, they actually grow up to be adults who have chronic insomnia. So the intervention here is to recognize that you can't change your genes or your upbringing, but acknowledging them kind of eases some of the stress that patients put on themselves, or why am I like this? Precipitating events often happen. Sometimes it takes more than 1 visit, 2 visits, 3 visits before somebody will actually tell you, especially if they suffered some trauma in their lifetime. But the sort of events that I hear mostly are devastating medical illness, divorce or marriage, death of a close relative or friend. Those are the big ones. The development of depression or anxiety. It's been a boom for business ever since the start of the pandemic. When I was in Los Angeles during that time period, I mean, a number of referrals that I got went through the roof because nobody was sleeping because of all the anxiety and stress of just how our lives changed back then. Perpetuating are internal messages that reinforce harmful behaviors and untruths. So people actually start to say things to themselves like, I need 8 hours of sleep, where that's not true for everybody. I won't be able to function without sleep. Losing sleep makes me a bad whatever. Trying to sleep or worrying about sleep. I've actually had patients in the past tell me, you know, when I go into my bedroom at night, I start to cry because I know I'm going to face another bad night. And then doing things that perpetuate the sensation of being in bed but not sleeping, such as eating, working on the computer, or reading in bed, all reinforce or perpetuate the chronic insomnia behavior. And the most important thing about this facet of the evaluation is this is what we address with cognitive behavioral therapy. So trying to get people to get rid of those negative thoughts, try to get rid of people that you don't go from sleeping 3 hours a night to 8 hours a night overnight, and trying to get them to have better sleep hygiene. So those are all components of cognitive behavioral therapy. Psychological and psychiatric factors often lead to chronic insomnia. Depression and bipolar mania will definitely lead to sleeplessness. Anxiety and panic disorders are among the highest reasons for patients to be sleepless at night. PTSD keeps people awake because bad things happen at night. And so we have people who are afraid to fall asleep, adults who are afraid of the dark, essentially. Psychosis generally has sleeping difficulties and sometimes day and night reversal. And then any kind of substance abuse, dependence, or withdrawal can all lead to or contribute to the disease of chronic insomnia. Substances other than, you know, illicit drugs or alcohol can change your ability to sleep, and people don't always understand or acknowledge this. But you know, allergy or cold medications that have pseudoephedrine in them definitely can keep people awake, and people don't know that. Some blood pressure medicines can lead to sleep-wake disturbance, especially actually beta blockers among older patients. Depression and anxiety medicines, you know, when we talk about the antidepressants, there are quite a few antidepressants that can cause disturbances in sleep-wake, and if they're taken before bed, can lead to or contribute to chronic insomnia. Pain medications that make people sleepy during the day discourage them from sleeping at night. And of course, caffeine and nicotine can contribute to sleep problems. Periodicity is an important thing to look at when you are evaluating somebody potentially with chronic insomnia. The classic example of this I give is when I see somebody who is a college student, and they've managed to schedule all of their classes for their first 2 or 3 years of college so that they never have to wake up before noon. And then all of a sudden in junior or senior year, they have an internship where they're expected to be at work at 7:30. And so they have, you know, insomnia because they can't fall asleep at 11 o'clock in order to get up at 6 o'clock in the morning to make it to work. The delayed sleep phase syndrome masquerading as chronic insomnia is very, very common. So it's really important to look at patients' self-proclaimed, you know, sleep schedule. This is not a hard one to figure out, but it's often a hard one to treat. Medical disorders are a huge contributor to chronic insomnia. So number one on the list for me is chronic pain. But people have symptoms of COPD, asthma, congestive heart failure, also acid reflux, and some neurologic diseases can contribute to chronic insomnia, unless we forget primary sleep disorders. So I would say probably 2 out of 10 patients that I see with chronic insomnia actually have an underlying organic sleep disorder, most commonly sleep apnea, which is actually contributing to their chronic insomnia. So if you look at the ICSD-3, everything is sort of lumped together now. When I first started to study sleep, it was still the ICSD-2, and they had all these different subclassifications of insomnia. And the problem is that most patients have more than one. And so being more lumpers than splitters, when the people who did the 2014 version of the ICSD-3 basically said, you know, it's better to just put everything together and recognize that there are different components of insomnia that can be helpful to evaluate and manage patients. So I'm just going to go through some of these. Psychophysiologic insomnia is probably one of the ones that we deal with the most. That's a heightened state of arousal, and also patients predisposing or they're perpetuating factors, which you can address with cognitive behavioral therapy. Excessive focus and worrying about sleep, elevated levels of cognitive and somatic arousal associated with the bedroom and bedtime. So psychophysiologic insomnia is like when somebody has a life event where they first have the problem with sleeping. A classic example of this is young parents who have a baby and have another baby and maybe another baby, and they go through a span of 6 to 10 years where waking up in the middle of the night is just a fact of life. And then the kids grow up, and one or both parents get to a point where they can't ever get back to sleeping normally again. Even though the kids are grown and they don't have any of the stressors or anything else like that, they have developed toxic associations with bedtime and bedroom that lead them to perpetuate their chronic insomnia condition. Fully treatable, but it takes a lot of time and it takes a lot of buy-in from the patients. Inadequate sleep hygiene is huge. Inconsistent maintenance of good quality sleep and daytime alertness. So people who nap during the day, people who tell you, if the first thing that I ask them when I ask them about their sleep schedule is that it varies, my sleep time varies. It could be midnight, it could be 4 a.m. I don't have a job right now, so I don't have to wake up for anything. Sleep hygiene and not having a set schedule can lead to just very, very disorganized sleep. Also not having a bed. I mean, I live in New York now where people are in a studio apartment, and so not really having a bed or not having a bedroom can lead to problems with sleep hygiene as well. Idiopathic insomnia is when I talk to somebody and they can remember having sleeping problem as a child. This is not that common. I would say it's probably less than 10% of the patients that I see, but I always ask people when I'm evaluating them, when was the last time you can remember sleeping normally? Was it when you were in college? Was it high school? Was it earlier than that? And some people will tell you, I can't ever remember sleeping well. I can always remember, having difficulty. Sometimes that's because of their upbringing or tensions in their household and everything. But idiopathic insomnia is persistent over time without remission. We don't really know yet. There probably are genes that control this, but we don't have consistent, like a blood test that you can do on somebody to say, aha, you have idiopathic insomnia. The important thing about idiopathic insomnia is I have found that cognitive behavioral therapy alone doesn't really work for these people. Most of these people do need a stable medical regimen in order to get them sleeping well some of them for the first time in their lives. Paradoxical insomnia. This is a favorite of the sleep board questions. Basically, it's when somebody has a misperception. That's the old name for this was sleep state misperception, and it's somebody that tells you that they never sleep, that they lay in bed all night awake, but they never fall asleep. This is common in patients who have psychiatric illnesses, whether it's active access to diagnoses or people who have psychosis. And the way that you basically diagnose this on is at some point you do a sleep study on these people, and you see that they're objectively sleeping. Maybe it's not the deepest sleep or the best quality sleep, but they're objectively sleeping 6 or 7 hours in the sleep lab. And when they write out their morning questionnaire after they do their sleep study, which I'm a huge fan of, don't let your patients sleep without that. They say, oh, I didn't sleep at all, or I slept 2 hours. I actually earlier today read one of those sleep studies, somebody that I have been seeing in the clinic for chronic insomnia, and she slept 7 hours. She slept 7 hours the other night in our sleep lab with a sleep onset latency of like 11 minutes. And her perception was that it took her 30 minutes to fall asleep. She was up and down all night, which she really wasn't. And she only thought that she slept 3 hours. So that's a very tough clinical situation, paradoxical insomnia, and you have to be very delicate with it in order not to offend the patient. Insomnia due to another mental disorder, and again, this is taken directly from ICSD-3. So most commonly, as I mentioned before, mood and anxiety disorders, psychosis, personality disorders, insomnia due to a drug or substance. Again, I covered this in the 6 Ps and an M directly from ICSD-3. The medical conditions, the primary sleep disorders. So going back to our case, what subtypes of insomnia does our patient have? Well, I think she had some degree of paradoxical insomnia. It's really uncommon for people to say that they go days and days at a time without sleeping at all. Through the years, I've noticed that my cutoff is about 3 hours a night. If somebody's sleeping less than 3 hours a night, they don't make sense. They have trouble carrying on a conversation with you. They look disheveled. Their thought process is disheveled. And if somebody comes in and they're well groomed, they have dressed well, makeup on, they're probably sleeping more than they're telling you. This patient has some degree of insomnia due to untreated sleep apnea. She has insomnia due to uncontrolled diabetes and her frequent nocturia. She has insomnia due to abuse or withdrawal of alcohol and cannabis. I will tell you, some of the most difficult to treat patients are people who are in recovery from alcohol addiction. If somebody has been drinking for 5, 10, 15 years in order to fall asleep, some of them never recover their ability to sleep normally again. Insomnia due to anxiety disorder. I think she has psychophysiologic insomnia very badly because she's has now some unhealthy associations between bed and bedtime and stressing herself out over not sleeping. And her sleep hygiene was just terrible. So there's a lot, to unpack here. There's a lot to do with this particular patient. So these are the evaluation tools that I use. First off, a very good sleep history and general medical history. I will tell you that when I see a chronic insomnia patient, those visits tend to be about twice as long as an intake visit for garden variety sleep apnea. It's a 40-minute visit. Depending on how much time I have on the clock, and if I have time, it can take up to an hour for that first visit to try to get as much down as possible. Patients really appreciate that, by the way. So if you have the time, nobody's ever asked me these questions before is something that I get very frequently. Nobody has ever asked me these questions before. You can be the star, you can be the hero for these patients. The other thing that I find essential is a sleep diary. Not so much actigraphy because it's not widely available and you can't bill for it. This is a version of the sleep diary that I use. It's from, if you look at the fine print at the bottom, it's freeprintablemedicalforms.com. I love this, and I'm not going to go through the whole thing in an interest of time, but on the left-hand side, you'll see where it says day, that column, there's 14 spots, so it's 2 weeks. The day starts at 6 p.m. and goes to midnight, 6 a.m., noon, and 5 p.m. And what you tell the patient to do is when they are getting into bed for the first time at night, they have to write down what time it is. And then you tell them don't journal in it, don't write things down in real time as things are progressing. But you tell them when they get out of bed and don't go back in it again, they write down that time. And then each of the rectangles, they fill in a S for sleeping and a U for up during that time period. And if somebody does this for about 4 weeks, 2 pages of this, you can get it, and they do it, and they really concentrate on it. You can get a really, really good idea of what their sleeping patterns are. You're looking basically at, I count up all of the S's and I figure out the average number of times or number of hours per day that they're recording or reporting that they are asleep. And then looking at actually when their natural fall asleep time and wake up time is very, very instructive. We find a lot of people who actually are on the delayed sleep wake phase spectrum who go to bed at 9 and they don't fall asleep until 12. And then they only sleep 5 hours and they get, but they're staying in bed until 9. And this is my biggest weapon against that is basically using the technique of sleep restriction for sleep consolidation. It works extremely well in conjunction with a thoughtfully filled out sleep diary. This is just a slide from an actigraphy. I don't know if anybody's using these out there anymore, but basically this is a medical grade Fitbit. It actually records motion and light. And from that, in the areas in the aqua on the slide, that's supposed to be when the patient is sleeping. Again, a useful tool if you have it, not essential. I can tell you that because I haven't been using it for several years. But when I was in the Army, we used this quite a bit. Sleep study is not indicated for the evaluation of insomnia unless there is a valid indication and clear rationale. And so basically what you have to be aware of is that insurance companies will use this against you. So if your diagnosis is insomnia, bottom line, and you say sleep study in your orders, it can be denied and it can be difficult to, even argue that down. Basically what you want to do is you want to use euphemism like difficulty initiating and maintaining sleep with excessive daytime sleepiness. And if you use the excessive daytime sleepiness, then you can get the sleep study. Okay. I tell people in my practice, most people end up with a sleep study. And some people are expecting a sleep study as part of their sleep evaluation. And I tell people, if you hang around the barbershop long enough, you're going to get a haircut. So basically, just about everybody in my practice does at some point end up with a sleep study. And the method of choice, of course, is to do a polysomnogram because home sleep apnea testing doesn't accurately record sleep versus wake. I'm just going to one slide on cognitive behavioral therapy because we could do 3 different lectures about this right now, but it is an intervention that helps patients improve the sleep, teaching them to change their dysfunctional thought patterns and behaviors. And the components of CBTI, I lied, 2 slides: stimulus control, sleep restriction therapy, cognitive therapy for dysfunctional thoughts, sleep hygiene, and relaxation techniques. I will tell you that finding a good psychologist in your community that actually does this can be very hard. Most of them do not take insurance in the places where I have lived, so it can be a little pricey. And the other thing is that some clinical psychologists who do CBTI are very anti-medication. And I will tell you that I've had the most success combining techniques of CBT with the least harmful medications that I can when I'm treating people with chronic insomnia. This is interesting. This came out in 2017, and if you haven't seen it, you should look for it. It's from the Journal of Clinical Sleep Medicine, and it was a clinical practice guideline. It's a huge article. It's 74 pages long, and the last 30 or so pages are all appendices. And what it basically did is go through and systematically evaluate all of the common medications, which are either FDA or non-FDA approved but used for sleep, and looked at all the evidence-based medicine for them. And the evidence-based medicine isn't that great, really. And for that reason, they say trazodone shouldn't be used, melatonin, diphenhydramine shouldn't be used. But they do say yes to most of the, or really all of the FDA-approved medications that we use in the classes that we're going to speak to a little bit more in a minute. So now I'm going to finish up the talk pretty much talking about the medications, because I think this is the thing that might be most helpful to you, especially those of you that are in training. There are basically 5 different kinds of medications that we use in order to treat insomnia. And this is unpublished. So if you do use this in your own practice or to teach others, just remember where you got it from, please. This is the Grbach grid, I call it. Basically, this really helps you to understand how the different medications work. So everything, if you look on the left-hand side, are medications that turn the sleep circuits on. And those include the GABA receptor agonist and the melatonin receptor agonist. So they turn on sleep pathways, or wake off. Okay, wake off, they turn off histamine, or they turn off orexin, and that's how they promote sleep, by turning off wake promoting neurotransmitter pathways. So to go through this a little bit more in depth, this is a very scary picture, but you got to learn this stuff for your boards. This is the sleep promoting GABA system. GABA is the major inhibitory neurotransmitter of the brain. It's found in multiple structures. The most common CNS GABA receptor has 2 alpha-1, 2 beta-2, and 1 gamma-2s subunits. And basically, depending on where a ligand binds to the GABA receptor, will determine whether it's mostly a hypnotic, an anxiolytic, anticonvulsant, amnesic, but there's a lot of crossover with the medications. GABA binds itself between the alpha-1 and beta-2 subunits. Alcohol has its own binding spot, as do the benzodiazepines and BZRs. The net effect is that chloride channel in the middle of the subunits will open up and allow an influx of chloride into the cell, depolarizing it and promoting sleep. Now, to talk a little bit about the common FDA-approved medications for activating the GABA subunit. This is taken from the appendix of the landmark 2017 clinical practice guideline. And basically, this is a little chart of the evidence-based medicine surrounding zolpidem. And if you squint, you can basically see that all of the evidence in the second column is either low or very low, except for one study, which was moderate. And if you look on the right-hand side, it tells you how many test subjects there were and how many studies. A lot of them are pretty small. And both the objective and the subjective improvements in sleep are pretty meager when you really look at them. For instance, the mean sleep latency on a sleep study for patients taking zolpidem 10 milligrams versus a placebo was only 11.65 minutes. All right, so that's not that fast, but you can see that there are pretty meager improvements with zolpidem compared to placebo in all of these studies. Now, contrast to that, to what I consider the big gun, the thing that I never want to prescribe, but sometimes I have to, and that's temazepam. Temazepam 15 milligrams is basically the strongest FDA approved benzodiazepine that we have for sleep. And it really is objectively very strong. For instance, if you look on the third line there, total sleep time, there's high quality evidence, although it was only 34 subjects in one study, that shows that the mean total sleep time increased by 99 minutes with the use of Restoril or temazepam 15 milligrams. If I really need somebody to sleep, if somebody's in a if I get called by the psychiatrist for somebody who's severely depressed and they need to sleep, I will pull out the big guns. I try to use azopiclone more. Azopiclone is stronger than, objectively, if you look in this article, objectively stronger than Zolpidem, but by far temazepam is the strongest thing. So try not to use temazepam, and the reason why I say that is when you give somebody a medication which makes them sleep, they get lazy and they don't want to do the cognitive behavioral therapy things. So that's one of the problems when patients come to me and they're already addicted to sleeping pills, is that they have been fed medications that work very well to help them to sleep over a period of months or years, and they've never had to do the hard work of evaluating why they can't sleep, and their behaviors, their sleep hygiene, and their perpetuating behaviors flourish against the background of medication. I mean, if I can go 100 miles an hour and then take a pill and fall asleep and wake up 6 hours later and feel reasonably well, I'll do that until it doesn't work anymore. We're going to talk a little bit about melatonin. Melatonin is a agonist of the MT1 and the MT2 receptors in the suprachiasmatic nucleus. And I'm looking at my time here, and we don't really have time to go through this, but this is something really worth studying. It's very interesting, fascinating. I actually use a lot of melatonin in my practice because I really do think it helps to induce sleep. There are also Ramelteon and Tasimelteon, which are available. Tasimelteon is used for the non-24 of patients with total blindness. Ramelteon, it is sort of a niche drug. I try it on some people. If prescription, if over-the-counter melatonin meets their needs halfway, sometimes they will respond to Ramelteon. More often than not, though, it's kind of a dud, honestly. Then you have your some of your wake-off drugs here. That's the orexin antagonists. Suvorexant, lemborexant, and introduced earlier this year, daridorexant, are basically the antagonist of the OX1 and the OX2 receptors, and they trick people into thinking that they have narcolepsy. Is an easy way for me to remember it. So if I have type 1 narcolepsy, I am absolutely deficient in orexin and the orexin producing neurons. If you block the orexin system, you make somebody sleepy like somebody with narcolepsy. So that's how I learned and how I remember. Also, the sexy way to call them now is to call them DORAs, or dual orexin receptor antagonists. I find these are great drugs to use in patients who are already addicted to benzodiazepines or BZRAs and failing. I don't find standalone use of the DORAs very helpful, but as a rescue medication, I've actually had some amazing successes of people who were taking huge amounts of Xanax or Ambien or Restoril, getting them either completely off of those medications or down to very manageable doses, safe doses, by adding on a DORA. Now, I'm not going to talk about the full category of the antihistamines, the H1 receptor antagonists. I'm using doxepin as a paradigm here. You know, doxepin was once, it's a tricyclic antidepressant. And the problem is when you took it at a dose of 75, 100, 150 milligrams, you slept all day. And so when Ambien started to get a lot of bad press, and there were the article that was published that said that it led to falls and hip fractures, we started looking for an alternative for elderly people. So Silanor, Sinequan, which was the old trade name, for doxepin, was rebranded as Silanor, and it's a tiny little doses, 3 milligrams or 6 milligrams. And it really works very well for senior citizens. Very low side effect profile. Now, the problem is that Silanor, the brand name, is very, very expensive. So 3 milligrams, 6 milligrams, while they are the recommended doses, I get very good success without side effects from using the generic 10 milligram doxepin capsule, which is dirt cheap and very well tolerated. And I give it to grandmas and grandpaps, people in their 70s who can't sleep. A single dose of doxepin, or maybe melatonin combined with doxepin, can treat the most stubbornest insomnia in elderly people. Very safe, very low side effect profile. I had to put this in here. This, of course, is the drug that we use for type 1 narcolepsy, and now it's has been approved for idiopathic hypersomnia. But basically, it's sodium oxybate, or sodium gamma hydroxybutyrate. It is a GABA receptor, but at the GABA B receptor, and then it has its own unique receptor, and it is a very, very powerful hypnotic medication. Again, we don't use it for insomnia, but in the interest of completeness, I put it into the chart. So this is just a review of the different types of medications, the different classes of medications, and how they work. And again, this is looking at the Grbach grid here. And so the reason why I say that is that if somebody is already using a benzodiazepine in order to sleep, often changing them to something else in the GABA agonist sector here doesn't work that well. You have to use something different. You may have to use a melatonin receptor antagonist, or introduce a histamine receptor antagonist in order to combat that. And if you look very carefully here, so at the doses that we use for insomnia, trazodone is primarily antihistamine. So at the low doses of trazodone, same thing with mirtazapine at 7.5 or 15 milligrams, has a lot of antihistamine to it. And then I really like Unisom, or doxylamine. It's stronger and lasts longer than Benadryl, and I don't see a lot of side effects from that either. Not really the hangover. So, all right. So insomnia treatment for our patient, for her inadequate sleep hygiene. I wanted to teach and enforce and reinforce all of her bad habits. For her psychophysiologic insomnia, I started basic in the office cognitive behavioral therapy, kind of CBT light. I haven't gotten her successfully to do a sleep diary yet, but we're getting there. For insomnia due to anxiety disorder, I've insisted to the point where she now has a mental health practitioner. She has a sort of social worker and a doctor, and we're thinking about medications. For a paradoxical insomnia, there's no treatment, but hopefully this can resolve spontaneously when she's sleeping a little better. For her insomnia due to abuse, withdrawal of alcohol and cannabis, she's still abstinent from alcohol. She's still using THC and CBD. We're working on that. That can be very hard. Insomnia due to her uncontrolled diabetes, not my job, but I have her I'm trying to confine her to one good internist that I know who can tolerate this complex and hard to manage patient in order to get her to change some of her habits and maybe get on some medications for diabetes. And then the untreated sleep apnea, eventually I'm going to get her another sleep study and figure out where we are with there. Hopefully, hopefully if she has, very mild sleep apnea, sometimes PAP therapy is actually worse than nothing at all. If their apnea-hypopnea index is like, just barely into the mild range. So maybe we won't have to deal with that. So that's the end of my talk. And I'm available for questions. We have about 5 minutes here. Trying to see how I